Good morning to all. Welcome back to Open Med School. In the last session, we have discussed the etiology and pathogenesis of GBS. We'll start with a case. This is the history of a 11-year-old boy who was absolutely normal 10 days back. He noticed weakness of his lower limbs in the form of difficulty in walking, and in the next 24 hours, it progressed to weakness of the upper limbs, and he had difficulty in raising his hands above shoulder, and his hand grips were also weak. 2 weeks prior to this, he had an episode of diarrhea with fever, and he complained of some paresthesia, numbness in the lower limbs, and some pins and needle sensations. On examination, his vital signs were normal. He was conscious and cooperative. His eye movements were normal. Cranial nerve examination showed bifacial weakness, lower motor neuron type. Motor system examination showed hypertonic and irreflexic upper limbs and lower limbs. His muscle power was grade 2 to 3 in the lower limbs and grade 4 in the upper limbs. Plantar was flexor. Sensory examination showed no objective findings, even though he had some paresthesia. His bowel and bladder functions were normal. So this is the typical presentation of a acute inflammatory demyelinating polyneuropathy or GB syndrome. So what is the typical presentation? It is an ascending paralysis. It is an acute paralysis. It is flaccid one. It is irreflexive. And no upper motor neuron signs like an extensor plantar or bladder usually. Patient may complain of significant sensory symptoms, especially distal paresthesia. Distal means it is in the lower limbs. Sometimes in the upper finger you can have some symptoms in the upper limbs also. But testing for sensory dysfunction is very unusual. As we have mentioned, this is a disease of the peripheral nervous system. So peripheral nervous system has got an autonomic component also. So autonomic nervous dysfunction is also very common. And the common manifestations are in the cardiovascular autonomic dysfunction. So that is, they come with the cardiovascular dysreflexia. Usually this presents as orthostatic hypotension, paroxysmal hypertension, tachycardia, bradycardia, or sometimes arrhythmias. This can affect the sweating, so there can be diaphoresis or altered sweating pattern can be there. Rarely the bladder function can also be affected, but it is not a usually it's not a common thing. So point to be remembered is it is a purely lower motor neuron dysfunction. It is bilateral, it is symmetrical, it is irreflexive. At least in 2 limbs it is symmetrical, that is lower limbs, it is lower limbs. That is why it is called ascending type of paralysis. But there are different variants are there. So we should be careful about the variants. So these are, as mentioned, GBS is not a single disease. There are a group of disorders having some common manifestations. Let us look into the different types. What we have described is the acute inflammatory demyelinating polyneuropathy, the demyelinating type of polyneuropathy. The pathophysiology we have discussed already. Second, another group is acute motor axonal neuropathy. Here the axons are damaged. So that is again, this can be differentiated mainly by the nerve conduction studies. Clinically there is not much difference. Then motor sensory axonal neuropathy. So there will be predominant sensory findings. And the most important is the Miller-Fisher variant. In Miller-Fisher variant, there is ophthalmoplegia. Starts with cranial nerve dysfunction, diplopia, ptosis, ophthalmoplegia. On examination, there will be irreflexia. Usually, they don't develop weakness, but sometimes, rarely, this may progress to weakness also. And when cranial nerves are affected, always remember botulism, myasthenia, snakebite, and brainstem encephalitis. So this descending pattern, starting from the face or starting in the pharyngeal muscles, should be careful. Again, the problem is they can develop respiratory paralysis. Then acute autonomic neuropathy, that is only the autonomic nervous system is affected. As mentioned, it is the autonomic part is more affected compared to the somatic nervous system. And again, pure sensory GBS. Sensory findings are present in most of the cases of GBS, but examination there is not findings. In some patients, it can be significant pain, lumbar pain, or a shoulder pain that may be confused with root pain. So this should be kept in mind. And other variants we have mentioned there. Most important is the pharyngeal, or starting with the pharyngeal muscles and then cervical and brachial variant of GBS. Pharyngeal, cervical, brachial variant. As mentioned, these people are more prone to develop respiratory problem. And again, this usually occurs 1 to 3 weeks after an upper respiratory infection or a gastrointestinal infection. Starts in the lower limbs typically, that is why it is ascending, paresthesia, numbness, tingling. Later they develop paralysis. And as mentioned, there is areflexia. Muscle pain and cramps can also occur, and some days there is hyperesthesia that can be worse at night. Among the cranial nerves, the most important is the facial droop. It is usually bilateral, but suppose there is some minor asymmetry, this may be confused as Bell's palsy also. So the patient can come, when the ophthalmoplegia is there, you can get diplopia. When the pharyngeal muscles are affected, there can be dysarthria, dysphagia, and sometimes pupillary abnormalities. Again, remember, these are part of the autonomic nervous system, and so they can be also affected. So as shown in this picture, you can see there is a difficulty in closing the eyes, more on the left side, and you can see the Bell's phenomenon also. On testing, you can see that he has got a bifacial weakness, so sometimes this may be confused with the Bell's palsy. Sensory we have already described is paresthesia, pain, and subjective sensory rather than objective findings. And clinical manifestations of autonomic nervous system can lead on to cardiovascular dysreflexia, mainly hypertension, bradycardia, heart block, and even asystole. So this can lead on to mortality, and paralysis of the respiratory muscles also should be kept in mind. So the most important complication that you get in GBS is due to respiratory paralysis, the most serious problem. The typical respiratory symptoms you can get, even sometimes the presentation can be, they may come with dyspnea on exertion, shortness of breath, difficulty in swallowing, slurred speech, and finally they can develop a ventilatory failure. So somebody complains of muscle weakness with some respiratory difficulty, always think about the possibility of the clinical presentation of typical GBS and also the variants. Hope this was useful to you. We'll come with investigations and management in the next sessions. Thank you.